I'm going to present, my topic is diagnostic management of graft failure. So let's go and see the definition, graft definition. Graft definition is in HSCT is an essential goals, as we know, for the sustained long-term and effective of the hemopoiesis. It is important for the criteria for the better overall for survival. So engraftment is nothing but is defined as the first of 3 consecutive days with the absolutely neutrophil counts higher than 0.5 into 10 to the power 9 per liter, sustained greater than 20 into 10 to the power 9 per liter platelets, and hemoglobin is higher than 8 gram per liter with free transfusion requirement. So let's see the definition of graft failure. The graft failure is nothing but
Hello, Eugenia. Can you switch off your microphone?
Hello.
Also, hello, Eugenia.
Yes,
I think we can hear your voice. You can also switch on your video, switch off your video also.
Okay, we'll go and see the graft failure definition. The graft failure definition is the graft happen when the new cell don't make the new WBC counts, white blood cell counts, red blood cell counts, and platelets as we need. This is also known as the failure of graft or non-engraftment. This is serious in our patient, or commonly although incident related to low graft failure. When it does occur, it is a major complication. So it is associated with dismal prognosis, particularly in our recipient. Actually, the donor stem cell is more important. It is remain as important for the patient. They will have the mortality, the rate of mortality and mortality rate. It will be high after allogenic stem cell. So the meanings, graft failure is defined as the lack of hematopoietic cell, and engraftment following autologous allogenic stem cell is classically divided into primary and secondary graft failure. So we'll go and see the it's divided into 2 parts, primary and secondary. So first we'll see about the primary graft failure. So the primary graft failure, the NNC is higher than 0.5 into 10 to the power 9 per liter by the day plus 28. The hemoglobin will be higher than 8 G per liter, and the platelets will be higher than 20 into 10 to the power 9 per liter. So in confirmation of the donor cell origin is required up to the day plus 42. The secondary graft failure, the NNC will be higher than 0.5 into 10 to the power 9 per liter after initially engraftment, but not related to relapse, infection, or drug toxicity. Loss of donor hematopoiesis to higher than 5%. So poor graft function. 2 or 3 in the poor graft function, there are 2 or 3 cytopenias with the 2 week after day plus 28 in the persistence of donor chimerism is less than 5%. Graft rejection, graft failure caused by the immune rejection of the donor cell is mediated by the host cell. So we'll see primary graft failure is defined as the evidence of the engraftment or the hematological recovery of the donor cell within the first month after transplant. Primary failure is essentially more significant of mortality and mortality rate. Second graft failure refers to the loss of previous function graft resulted with the cytopenia involved, as I show in the first slide. So the risk factors associated with the graft failure. Graft failure may be because of low CD34 counts, maybe insufficient conditioning like chemotherapy, maybe abnormalities in the donor hematopoietic stem cell transplant, or maybe abnormalities in the host microenvironment, maybe because of the drugs, maybe because of the infection and the immunity, graft rejection. And here some studies will be showing like HLA dispersibility also, like the patient will be having this graft failure. If the HLA mismatch is associated with the high risk of graft failure, HLA class 1 are important determinant of the graft failure. So ABO incompatibility, reduced intensity conditioning, primary diagnosis, graft sources, cell dose, graft manipulation, and others. So we'll go and see here one by one. So in HLA, first we'll go about HLA. In HLA, mismatch was associated with the high risk of graft failure. HLA class is important to determine the graft failure. So ABO mismatch for the donor and recipient conclude that the major ABO incompatibility does the affect the still remain the risk factors of primary graft failure. And next, number 3 is reduce intensity conditioning regimens. Have lower dose of chemotherapy, it has immune system may be persist, resulting in the increased rate of the graft failure. So diagnosis, the primary diagnosis, it may be affect for the graft failure indirectly due to difference on the pre-transplant chemotherapy protocols. And next, we'll see about the graft sources. Graft sources in bone marrow is consistently associated with the delay of neutrophils and platelet counts, platelets engraftment. So cell dose CD3 cell in peripheral blood stem cell is likely facilitate engraftment, as we know, to contribute the lower incidence of primary graft failure. In bone marrow graft with the low cell dose, the total count dose will be less than 2.4 into 10 to the power 8 per kg, result be 40% increase in the graft failure. Other risk factors, some patients they will have this viral infection, example as CMV infection and HHV6, parvo, and sometimes because of this viral infection, we use the drugs like ganciclovir, so it may be affect the graft failure. So management of graft failure. Management of graft failure is nothing but if early we identify that the patient, his counts is not improved, so it may be prevent for the graft failure, and maybe we can increase the immunosuppression drugs. So first we'll see about the change in immunosuppression drugs. So modify the immunosuppression drugs by adding double immunosuppression drugs. And next is DLI, donor lymphocyte infusion. Donor lymphocyte infusion is we are giving for the patient who are immune rejection by administration of DLI after the day of 100. The patient who had the immune rejection with the mixed chimerism. So next is CD34 boost. So for CD34 boost, so we prefer for the patient who had the hypocellular with poor engraftment function, but probably after the days of 28 to 2 to 3 months without improvement. So autologous, we prefer for the, like especially for the partial match patient. So after giving this bone marrow, maybe they be rejected. So we prefer for the autologous backup. And next is regrafting or the second allogenic transplant may preferred. So initial measure it is important for this as soon as graft failure we suspected. So we should stop all the many toxic drug as possible. We should treat, if patient had infection, we should treat that infection. And And adjust post-transplant immunosuppression drugs is very important, and maintain the correct level of immunosuppression drug as early post-transplant. Later, after third or 6 months of mixed chimerism is present, especially when the transplant as faster we are tapering the immunosuppression drugs, it could be overcome with the mixed chimerism. And in the patient of severe aplastic anemia, it is also common to recommend that it will increase the immunosuppression drugs. So key points: graft failure is the infrequent but often fatal complication of the HSCT. Etiology is complex, is very infrequently in multifactorial. Preventive measure and early identification of the potential cause in order to treat, reverse them as the key aspect to treat it. And in nursing consideration, in nursing care for the patient who are going under the LCT, it should be aware of the possibility of the graft failure following the transplant. When the patient is failed for the engraftment, also the patient will be his life will be life-threatening situation, and the patient will be sometime like there will be fear and then disappointment for the graft of the transplant, and then we should give them a psychological like support. Equality important for the physical care, for the emotional support for the patient, both for the patient and the family members about the situation. So this is bibliography.
Okay, thank you, Fika. Now I want to make just a couple of comments. Of course, yes, this is a bit of a difficult topic with a lot of controversial things, but I just want to underline the fact that in allogeneic transplant, engraftment, yes, is measured by the increase in white count, platelet, hemoglobin, but probably the most important factor is chimerism. As you know, chimerism means the amount of donor DNA that we can detect in the blood. And that makes a big difference, because sometimes we have decrease in white count platelets post-transplant for different reasons. But when the chimerism is good, then that patient has engrafted, and this can be caused by infection and other things. The other point I wanted to make is that many centers that use peripheral blood stem cells that have many more T cells will try to improve poor engraftment, in other words, a high degree of so-called mixed chimerism, by decreasing immune suppression. We use a less aggressive graft. In other words, we use bone marrow, and in particular GCSF prime bone marrow, so that in our hands, increasing immune suppression is more effective. But so many people may not agree. And so some centers, depending on their graft